Well, we're a couple past, so let's go ahead and get started. I'm sure we'll have others continue to trickle in as we get forward. So first off, more than anything else, thank all of you guys for coming. We have a lot to cover today, and we'll try and allow some time at the end of the presentation for questions, but we know going in, we won't get to everyone's questions. So what we will ask you to do is, as you have questions, just put them in the chat box. And whatever we don't get to live, we will commit to you. We'll go through it. We'll list the questions that every single person has asked, not by name, obviously, but then we will answer all of those questions and distribute that to everyone who's signed up. So even if we can't get to your questions live, know that we will answer your questions. With that, let's move forward a little bit. For those of you who've been on, you've heard us just chit-chatting. So there's 4 of us who will be presenting today, and we 4, in addition to Adam Moreau, who's our FlexPro Grip co-founder, have been working on these guidelines for the past 18 months. Each of us have worked really hard, along with the contributors that you will see listed on the bottom, to try and create what we think are really the most evidence-based rehab guidelines that exist today based on all of the available technologies. Our goal today is not to try and share with you every single thing that we've identified in the documents themselves, which we will be happy to share with all of you when we're done. There are kind of 4 components to that. There's a fairly lengthy 25-page narrative with full citations. There are step-by-step training protocols in the document as one of the attachments, which really show you exactly what we think should be done from a training perspective, truly from week 1 to the time a guy returns to playing full competition. We break that narrative into phases so you can see exactly what we think the goals and progression should be and the benchmarks to move from phase to phase along the way. And then we identify some very specific throwing programs that detail volume, intensity, frequency, all match to where a person's at. So rather than the 1-page sheet that people often get when they go into a rehab program, we think it's important to create a level of customization, and that's what we strive to do with the throwing programs that we would recommend. Now, that being said, probably the most important question that we had to answer when we even began this journey was like, why do we need another set of rehab guidelines? What's going on in the industry that makes us think that we needed to do something different? And I think there's probably no one better to answer that question right now than Dr. Fury, who's been involved in some seminal research surrounding this topic. So Matt, you want to talk a little bit about that and why you felt like this was something that was worth undertaking?
Yeah, absolutely. Thanks, Daryl. The UCL surgery with regards to injury, diagnosis, indication, surgical execution, we've come a long way, right? With regards to the treatment of medial elbow insufficiency. But in certain ways, we have not progressed over time. Historically, we've talked about return to play, and that was our benchmark. That was our benchmark for assessing surgical success. And we kind of did this study a couple of years back, which was the first to use advanced analytics and to go back and look at, return to play isn't what the athlete cares about, right? It's not what your patient cares about. It's not what your players care about. They want to return to perform. They want to return to a level that's satisfactory to them. And just simply getting back on the field is one part of that journey, but that is not the end game. And so if you go back and use advanced analytics and look at how these guys are coming back, our study a couple of years back showed that, number one, the percentage of throwers returning is a little bit lower than I think we've colloquially discussed. And 2, when they do return, they're different. They're different with regards to some pitch movement metrics, with regards to spin rate. And a recent study by Dr. Chris Ahmad, they looked at, again, advanced analytics, found that 70% had failed to achieve their prior performance within a 3-year sort of post-surgical follow-up. And the idea of returning to performance, I think, is critical for these guys because the game continues to evolve. These athletes are out for 12, 18, 24 months, and the game doesn't stop. Average velos continue to rise. The pitch design pursuit continues, right? These guys just get better and better. The game gets better, and the athlete would expect of himself to have improved too as well. So simply getting back on the field is not enough. Simply getting back to where you were previously is behind your peers. And so I think that's where we just had to reframe what our goals are. And our goals are returning to a level of performance that matters to the athlete. And so with these analytics, with these new equipment and tools that we have available to objectively measure certain factors of the recovery process and to then train them in an intentional way, I think we've got a lot of opportunity to improve on the rehab side of things. Because if you go and look at, they have studies that have demonstrated that a high percentage of patients have some form of a setback along the way, whether it's requiring a deload, having some pain that's needing an intervention, some anti-inflammatories or whatnot. We just haven't been as good historically as I think we have just sort of assumed. And so that's been our pursuit here. That's why we've worked on this for so long is we just want to be better.
Dr. Brolinson, we good, or do you have anything to add to that?
No, that's a great summary. Thanks for that, Matt.
Perfect. So with that, the question we first wanted to understand is what's kind of the industry standard? Certainly, all of you are familiar with lots of different protocols or variations off of some. Mike Reinold and Kevin Wilk produced a publicly available study in 2024 where they outlined what they thought were best practice return to throw guidelines then. Then there's an MLB standard, and for those on the call for Major League Baseball, I think you'll be fairly familiar with that protocol. And then we looked at ours. And this for us is in many ways the money slide and will shape how the rest of the guideline presentation today goes. And what we did is we tried to identify a host of variables, how others treat those, and then how we think our guidelines are different. And for the rest of the presentation, what we'll do is we'll just go through each one of these to talk about what we think is important and why we think it's important and how our guidelines go about treating these. So whether that's talking about criteria to begin return to throw, whether that be general or specific to the elbow, we think objectivity is key. We think forearm loading should begin earlier than most begin forearm loading. Return to throw to date, we don't differ in any way on when we begin return to throw. I think we differ on the criteria that shapes whether or not that's going to happen. Certainly when we get to throwing intensity and how we regulate that in our return to throw, we think we differ considerably because we think velo and IMU, if it's available, is considerably superior. But we'll talk a little bit about the concept of acute to chronic workload ratios and using that to manage the return to throw. Mound introduction is a tad earlier than one of the studies and significantly than what the MLB standard is. Where we differ considerably is when we think we should start introducing change-ups and breaking pitches, and one of our contributing authors, Chris Martin, was extremely helpful in shaping some of our thinking on that. Then we just talk about the way we value throws, how frequently you have to throw at high intensity to get someone ready to truly return, not just to play, but to return to a level of performance that gets the athlete where he wants to be. Then we'll finish just talking about this concept of customization and how we customize return to throw in our model. And then spend a little bit of time talking specifically about deload weeks and the criteria that we think are important to return to play. So with that, let's just progress and keep moving. First, in terms of the general criteria that we think ought to be met to begin a return to throw program. And with that, we'll turn it over to Dylan Newcomer. Dylan has his own private practice physical therapy clinic and also is the head physical therapist at Driveline. So with Dylan, you want to walk us through your thoughts here?
Yeah, thank you, Daryl. So yeah, really, this whole slide is what we're talking about from day one of rehab up until we actually hand an athlete the ball. And so before we ever even start throwing, this is the filter that I'm going to view everything through. A lot of guys end up getting cleared because they feel good or because the calendar has said it's 6 months, but good really isn't a metric. Strength, capacity, and your readiness actually are. And so the guiding principle here is really simple. Don't give a ball to an athlete that has an underprepared arm. And if we don't restore that baseline capacity first, we're really asking a less resilient system to tolerate more stress than what we were asking it to do before it got injured. So we'll go through a couple of the key points here, but we'll dive into it more later. One of the big things for us is internal rotation strength, but more consequently, the structured reintroduction of valgus loading throughout the rehab process. I think it's one of the bigger missing pieces in the return to throw aspect, or getting ready for the return to throw, and we'll dive into that specific piece in the next slide. But we have studies that show that athletes are being return to throw, like getting into that part of their rehab whenever they're upwards of 8 to 10% weaker on their throwing side, than their non-throwing side. We're essentially asking them to start doing what's essentially a plyometric action on a simply weaker structure. And for me, this is kind of like if we talk about an ACL knee patient, asking them to do high velocity single leg plyometrics whenever they still have like a weak quad. That's one of our first components. Another big component for us is the global lifts. And what I mean by that is just your general strength, like your general physical preparedness exercises, your bench press, your push-ups, your pulls, whatever it is that you and your organization and your staff are comfortable putting your athletes through. We want to get them back to at least 90% of what they were doing pre-injury before we hand them a ball. And before we ask them to return to competition, we want them well beyond that, 100% restored, and especially as strong as the non-throwing side. Another component, we like to use the ASH test for long lever force production, and we'll show some values later on for that. We think that you should be able to tolerate and hit certain benchmarks in those positions. And the final piece there is kind of an explosive upper body power progression. Things like plyo push-up patterns or being able to tolerate high velocity med ball throws or things along that line. Basically having those pain-free, repeatable, no guarding or any hesitation going on. And if we can hit kind of these benchmarks from a general sense, it feels more comfortable to get the athlete into what we believe is a state ready to return to throw. I mean, you can move to the next slide for me, Daryl. And this is really a big concept for us, is that the internal battle of rehab is neurology versus physiology. Physiology takes time to adapt, whereas neurology is much quicker. And especially if you have athletes that are throwing 90 plus miles an hour, those athletes are going to be able to hit the gas pedal much easier and much faster than potentially their physical system is ready to take on. And it's when that neurological demand starts to exceed their physiological preparedness that the athlete starts to get into a position where they might be set up for setbacks or re-injury. And so our job really is to flip that. When physiological preparedness is either going to match or exceed that neurological demand, we're going to get a much safer progression, and the athlete's body will have the capacity to handle the stress that the nervous system is going to be producing in those later stages of the return to throw. There's another layer here as well, which is training economy. The more of these qualities that we can address before we start the return to throw, so the strength, the power, and just the tissue tolerance overall, the less that we have to juggle these variables once we actually start the return to throw. If you walk into this return to throw stronger, more resilient, the less of an impact that each new progression in the return to throw will have. And that efficiency really matters, because the further along we are in that return to throw, the better we are physiologically, the more freedom we will have to progress that skill safely. All right, so going into this, one of the components is our pre-loading or pre-return to throw valgus loading progression. Historically, most of the UCLR protocols start introducing internal rotation and valgus loading somewhere around week 8. We don't really differ from that. But if you look at kind of typically what's described in the protocols, it's usually some form of like a throwers 10 band series. Maybe you'll see a mention of a body blade and some perturbations, and maybe you'll see towards the end kind of the introduction of like one-arm plyometric dribbles and things like that. And these may kind of re-expose a similar movement to throwing, but there's nothing here that's really creating any adaptational stress. And that's really the big difference, is like re-exposure is great, but we need an adaptation to occur. So we need a progressive, tolerable stress that can actually stimulate change in the tissue's capacity to handle that valgus load. And so that's what our progression is designed to do. And so we walk through a 4-stage progression, first manipulating the volumes or the variables of load and velocity. So early on, just like most protocols, we start with a lower load and low velocity, basically reducing how much of an impulse we're applying to the graft site. So this is really just your basic band work and things along those lines. The early internal rotation exercises you begin to reintroduce. We don't differ too much here. I believe that BFR is a great tool to introduce into this time if you have it, but that's another story. As we move through the progression, the first variable that we want to move through is load. Velocity is really the variable that's going to impact the graft site the most, how fast that distal segment is moving through any internal rotation exercise. So we start to increase the load first. Things like your heavier IR, slow eccentrics, or like high intensity isometric holds. That way we start applying a stress to the system that is actually high enough to promote a adaptation in the area. And we start teaching the graft how to accept a little bit more of a meaningful load again. As we move further into the rehab series, we begin to reduce the load and start to progress the velocity a little bit. You can use things such as bands or drop catches, or my personal favorite is to start incorporating something like a flywheel here. And then our final progression leading into the actual phase right before you start throwing is to minimize the load as much as possible, all the way down to potentially something as light as a baseball, but you start moving the arm much faster through these positions. So this may be like oscillatory drills or higher velocity med ball patterns that are actually applying a decent torque to the elbow. And the whole purpose of this is just to retrain the athlete to tolerate load, move fast again, and more than anything, be confident in these positions. It's when these athletes don't have confidence in their elbow, they don't feel like it's actually been trained or stressed enough, that they kind of enter the return to throw with a high degree of uncertainty.
So now we want to talk a little bit about the specific criteria that we think ought to be in place to clear someone to return to throw. And it's tough to do that without first talking a bit about the injury itself. And I think the first thing that we all have to re-anchor on is this understanding that the UCL injury, quite simply, is a torque capacity problem. You throw a baseball, you place a certain degree of valgus stress on the medial elbow, and that has to be buffered by three different structures: the UCL, the RC joint, and the muscle tendon units which cross the medial forearm. And it's a fairly simple concept, but one that I think people often lose. And it's just this, if you're looking at this as a simple math problem. What we know is there's a strong correlation between how hard someone throws and how much torque they're placing on their elbow, nearly 1-to-1. Of course, anthropometrics will change that. If somebody's longer limbed or throwing sidearm, it will differ slightly. But from a rough paradigm standpoint, if a guy's throwing 100, he's going to place somewhere around 100 Newton meters of torque on his elbow. But the UCL has a fixed upper limit, and it's well beneath that total torque being placed on the medial elbow at layback. So the UCL makes some level of contribution up to a max, let's say, of 45. We get radiohumeral joint compression, which might add another 35 Newton meters or so. And to prevent a tear, the muscle tendon units which cross the medial elbow have to do the rest, for which there are three that matter most when you look at this anatomically. Those are fancy terms, FDS or flexor digitorum superficialis, ulnaris, and profundus. And all of them have very different functions, but they all serve to cover some piece of the UCL footprint. So what we have to do, because we know that we're operating with fixed limits on UCL torque and radiohumeral compression, the goal is to try and make this variable piece contribute as much or more than what would be left over to equal that mathematical equation. Because if we do that, if we can drive this number up, we can shrink the load on the UCL, which just puts us in a much better position in terms of overall forearm health. That also clearly then has implications for us from a rehab standpoint. We know, just well vetted in the literature, and Dr. B, you can address this more if you think there's a point that needs to be stressed, but we train muscle tendon unit strength throughout the process, but what we're really chasing is stiffness, because what we know is that a stiffer muscle tendon unit can offload more tensile force or more stress that might otherwise be shifting to the UCL. So throughout all of our specific both criteria and in our training, as we focus on forearm musculature, the goal is to improve stiffness and overall endurance capacity of these muscle tendon units. Dr. Brolinson, anything to add to that, or is that pretty spot on?
Yeah, I think that's well said. It's a simple concept, but really key to the whole idea of this process being successful.
Great. So one of the things that we learned in this process was a study that Dr. Brolinson and Dr. Fury led, a retrospective study. Dr. Brolinson, I don't know if you want to speak to this a little bit. Obviously, what the biggest takeaway is it just reaffirmed what we suspected going in, was that weaker forearm flexors were going to place people at significant risk. And that's when we looked at these two in this retrospective study. I know that's what we found, but I don't want to steal your thunder here if you want to talk through any of this.
So that you're exactly right. So when we started to see this, and Daryl and I have had this conversation before, many folks know I'm at Virginia Tech, and we were the first team to instrument football players' helmets with an accelerometer array way back in 2003 when nobody cared about concussion. And when what we noticed, well, first of all, that that was a crazy idea, putting accelerometers in the helmet, recording real-time head accelerations, and correlating that with the clinical diagnosis of concussion. We were a Riddell team at that time. We used the VSR4, and the Riddell had just produced a helmet called the Revolution, which was the anti-concussion helmet. A lot of controversy around that. People thought a helmet makes no difference in terms of concussion. Long story short, we started to see a divergence in our data. The kids that were in the Revolution had much lower head accelerations than the kids that were in the standard VSR4. There were several other teams at that point also using what we call the HITS device, the telemetry system, pooled our data, and sure enough, what we found in the lab, we predicted a 50% reduction in concussion, and that was what we saw with our actual on-the-field data. So I like to call that a smoking gun. And I won't get into all the details of that, but that's very similar to what we saw here as we started to look at the data that we had in our database. We started to see this forearm flexor muscle imbalance that was contributing to this or associated with medial elbow injury. Now, this is always the chicken or the egg argument, but to me, this is a very important smoking gun. And as I mentioned previously, we weren't able to measure head accelerations, and so even get at what kind of helmet design might reduce the risk of concussion. So for the first time ever, we have a device that allows us to measure this forearm flexor strength and put numbers to that. So I think that's the really exciting thing about this. Of course, much more research needs to be done, but this is the smoking gun that kind of got us going down this pathway.
So with that, what we know is all of this starts with forearm loading and this notion of when we load and how long we should wait before loading. And Dr. Fury, as a surgeon, obviously you can start to address comfort level in loading forearm. So I thought maybe you might speak to that for a minute as it relates to how early you feel we can start loading forearm musculature.
I think there's a spectrum here, right, with regards to the disease of the medial elbow. There's a spectrum with how much of the underlying flexor pronator is involved in the injury, right? We're seeing a higher percentage of throwers having partial tears of the flexor, older throwers having more substantial flexor tendon injuries. And so I think there's a spectrum here with regards to the initiation of loading. There's a couple things that we know, and a lot of this, driven by Keith Barr and a lot of the work that he's done, and also there's a lot of experience around here too, as well, is that early loading is beneficial for tissue quality, for tissues to lay down in the appropriate orientation, for overall biologic and biomechanical properties of the tissues. Now, early loading is not necessarily the fear. I think it's early, uncontrolled, unmeasured, unknown loading, which is the worry, right, from the surgical side. And so I think, personally, I'm okay with earlier loading as long as we're doing it in an objective and measurable way. And I think that's what a component of this program involves. And it involves being very measured, very gradual, with exposing the medial elbow to some of the stresses that we know it's going to need the capacity to withstand, right? And so that's where we've started this early loading, which again, obviously will differ based off of some of the various pathologies here, but I think it's a benefit of the program.
And you want to talk about what we're trying to achieve in loading in the early stages pre-return to throw, and then where we progress from there?
Yeah, and so when we talk about forearm loading, the goal really isn't just to like strengthen the arm, or get hypertrophy in the tissue, or make the forearm just kind of do stuff, like rice buckets, therapy putty, all that stuff. Our goal is to create a specific progressive adaptation in the muscle tendon units that are there to protect the UCL that Daryl talked about previously. And so beyond that, every phase of this forearm loading scheme is designed to have a distinct physiological purpose. And if we know what we're targeting and how we're going to target it and what's required to target it, then we can design a loading scheme that actually makes sense. So we kind of bucketed this down. There's a lot more detail in the actual document, but to make it concise, generally speaking, in our weeks 3 to 8 period, we start with kind of our low light loading, which is 10 to 30% of one rep max, or of our targets that are based off of some of the data. And the goal here is just to stimulate collagen remodeling and healing, provide that healthy environment that Matt was just discussing. It really kind of sets the foundation for what we want to do later on in this rehab phase. As we move into the middle stages, this is really where we start focusing in on generating that stiffness adaptation of those key muscle tendon units. So we begin to progress the tensile loading up into high intensity ranges that are required to actually stimulate that adaptation. But at this period of time, this is also where we start to implement some of our ballistic loading protocols so we can prepare the athlete for that and what we want them to do in this final stage in the bottom row here. And this is where we continue to solidify those stiffness adaptations, but also this is when we really start to hammer in on our ballistic application of force and our endurance training at higher intensities, so that way we not only get a stiffer muscle tendon unit, but we get one that can apply its force in a meaningful window of time and one that is much more fatigue resistant.
And then that translates obviously, Dylan, into return to throw.
Yeah, and so before we jump into kind of the rest of the presentation focusing on return to throw, just wanted to wrap this up a little concise slide of what we think we want to accomplish before we get to the return to throw and what we want to accomplish before we get to return to play. And we'll visit that again at the end. But return to throw, like I mentioned previously, our big goal is we want the athlete to be within that 90+% range of all of their pre-injury lifts, minus deadlifts and pull-ups. Those are a little bit more controversial and definitely something that needs to be considered based off of the athlete and experience and tolerance and many other reasons there. Flex Pro grip testing, or whatever forearm testing you may be using, but in our protocol, we're specifically talking about Flex Pro. We want to be at our 70% range at a minimum, but we'd love to see athletes greater than 90% of our targets for them. And then for the shoulder, both in kind of short lever and long lever positions, you can see kind of our criteria that we're recommending. We utilize a body weight ratio here just to kind of normalize that from athlete to athlete, but also we are, again, considering the limb strength index or symmetry index there, and we want to make sure that that throwing side is surpassing their non-throwing side. Okay, so now we're going to move on into that return to throw, and that's pretty much the focus of the remainder of the presentation here. And our model, return to throw, is typically going to begin around weeks 20 to 26, and this is mostly for UCL reconstructions. If you have a repair, you can shorten this down just a little bit, but our big thing is that time is not what's going to heal it. It's all the capacity that we've talked about up to this point. We want to make sure that we're respecting graft biology and the ligamentization timeline, and we're not going to rush this process. But we also know that roughly around week 20, if you've followed the guidelines at this point, this is a good time to start that return to throw. And one of our big differentiators here that we mentioned at the beginning is that we believe that regulating throwing intensity is probably the most important thing that you do in this entire process. And the big question is, how do we do so? In the past, historically, it's been distance, RPE. Occasionally, you'll get some velo guidelines that are relatively non-specific and could do with a little bit more specificity. Definitely believe that distance is not a good correlation to any form of intensity. The argument's been made 100 times. You could throw 90 miles an hour at 60 feet, or you could throw 45 miles an hour at 60 feet. It's just not a good measure of intensity when you're talking about a rehab protocol. Very similar with RPE. One athlete's RPE of 70% may produce a velocity that's significantly different than another's. And neither of these methods are really good when you start to scale this out population-wide. So to control stress, we believe that the gold standard would be the combination of velocity and utilizing an IMU, such as pulse or any of the other wearables that are out there, and monitoring the arm speed and the workload accumulation there. But if you don't have an IMU, we still believe that the very best option overall is to simply utilize velocity throughout the entire return to throw. Having as much experience as I've had over the last several years doing return to throws in person with many athletes, velocity, if you put a radar gun in front of an athlete, they're not just going to suddenly start throwing as hard as you want them to. If you tell them that I want this throwing set to be within this velocity range, they will stick to it, bar none, even whenever they go off and do it on their own. It's not like they're just suddenly going to try to beat whatever you're prescribing. Most athletes are sensible enough not to do that. And we know that velocity has a pretty strong intra-thrower correlation. We know it differs from thrower to thrower, as Daryl mentioned earlier, but from within the same athlete, we know that a steady accumulation of velocity will be our best approximation of a steady accumulation of torque.
So once we say we're going to create a throwing program, the real question is at a macro level is how are we going to manage this? And over the last 5 to 10 years, there's no question that the concept of the acute to chronic workload ratio as popularized by Gabbett has made its way into baseball. And we think there's great value in that. I suspect most on the webinar are familiar with it. For those who aren't, just a brief explanation. The whole concept of an acute to chronic workload ratio is to just figure out a way to measure or quantify how recent training load compares to a longer term training load. There are different variations, but most tend to look at an acute training load period or a short-term training load in 7 days. Others might use 9 days against a long-term training load, which would be like a 28-day period, and then simply creating a ratio of what's happening in the short term over the long term. And there have been multiple studies that have looked at that and found that ideally you would like to have training ranges, whether we're talking about throwing or any form of exercise activity, in a range of 0.7 to 1.3. So the concept there would be if you were operating at a 1.3 acute to chronic workload ratio, that would be interpreted as saying in your 7-day period or in that short-term period, you have increased your workload by 30%, 1.3 over what that chronic load would be. And in studies specific to baseball, one done by Meta specifically found that the minute you started spiking over a 1.3 workload was when you placed yourself at a significantly higher risk of injury. So with that, as we started modeling return to throw programs, we wanted to be very respectful of that data. Now, if you stay under 1.3, does that mean you're never going to get hurt? Of course not. If you go over 1.3, does that mean you're going to immediately get hurt? Of course not. Ratios tend to speak to the general experience, and certainly we want to have statistics be on our side whenever we can. So with that, we started looking at this concept of creating an acute to chronic workload for our return to throw program. The challenge with that is it doesn't matter what workload program you look at. Ultimately, what you're having to do is figure out how you're going to value any sub-max throw. There is no research, there is no study which defines how much torque or stress does a 50% throw create on the arm relative to a 75% throw, relative to 100% throw. Lots of people have made speculations. And the truth is, we have no formal research to say that anyway. We can look to the literature and try and just reason through what we think makes most sense. And that's what we've done with our guidelines. I suspect in the future, whether it be us or others, we'll figure out a more concrete way to measure this, but that's the best we have to go on now. So for example, there are a few different ways that do this now. So acute to chronic workload models tend to work within zones of throwing, and most tend to work within 10 zones of throwing. So a zone 10 throw would say that someone is throwing at 100% of their max velo. A zone 5 throw, for example, would be someone throwing at 72% roughly of their max velo. A zone 1 throw would be like a light toss at 50%. What we've done, for an example, and these are all well vetted in the narrative that you will see, is we create schedules based on someone's peak velo, so in this instance, 92 miles per hour. And then we just set target ranges as to how hard someone should throw over the course of this return to throw program. Also, any IMU would tend to do this relying upon arm speeds, and they would create arm speed ranges. So for example, a zone 5 throw might be an arm speed of 550 to 650 RPMs. And those tend to match pretty well with velo up until about the 70% range. Then there start to be some diversion. Most surgeons will use distance, and some of the more popular surgical protocols would say, we're going to use distance, but then we're going to match distance to rough approximations of velo. So once we have that, then the real question becomes, how do you value a throw? And for this, I will be the first to say that our valuation, we think, differs than that of probably the most popular IMU on the market, which would be Pulse. So the way you would interpret this, again, all in the narrative. So Pulse would value a throw and say that 2.3 throws made at roughly 72% of a person's max velocity is equal to 1 max effort throw in terms of the overall stress on the forearm musculature and shoulder. We think that's not nearly an accurate representation. We've done a fairly exhaustive survey of 50 plus pitchers and just asked them subjectively how many throws did they think they would have to make at 75% of their max velo to have it equal 1, or 50%. And you can see we created a scale that's almost like a 3-to-1 scale over Pulse. The impact of that means that we place less value on the stress of a sub-max velocity throw in terms of building capacity for that individual to ultimately be able to make max effort throws. With this schedule or valuation, we can then build out throwing models that essentially go back to how we would map this out if we were mapping out an acute to chronic workload ratio. The standard here is, if you look at the green lines, maybe a little bit difficult to see, but if you look at the green lines, that would be that safe corridor. The bottom green line would show us a -7 ACW floor. The upper green line would give us a 1.3. The red line would show what our acute to chronic workload model is throughout our entire return to throw program. As you can see, we never, ever, ever exceed the 1.3 ratio at any point in our entire recommended return to throw program. Contrast that to one of the more popular surgical programs out there, and this is what their program would look like. And you can see fully at this point, they are spiking an acute to chronic workload above a 1.3. We have this, I think this says 0, but the truth is it's 24% of the time they're actually spiking an acute to chronic workload ratio. Slide looks like it's slightly off. But the point is here, our goal is to be very consistent, methodical, so that we keep people in a safe range from the first, this would be day 7 of the return to throw, all the way till we're done. We're always creating this gradual progressive load. And I know, Dr. B, it's something you always talk about, this concept of creating real progressive loading throughout an entire rehab process.
Yep, specific adaptation to imposed demand. So I mean, that's the key. That's what that's what this speaks to.
So once we have that in place, then the question becomes, as we progress through return to throw, when do we start doing the things that pitchers really care about, is not just moving off flat grounds, but getting introduced to mound throwing and breaking pitches and the like. And Dylan, you want to touch upon this?
Yeah. And this is probably one of the biggest mistakes that I see in the traditional return to throw models. Is you typically will go through a very full, long toss progression. Many weeks go by without ever touching the slope. And we just know that you can get on the slope and not really have any form of an impact on your stress on the arm, of the torque accumulation on the arm. And so what we like to do is give you a recommendation that roughly anywhere between about 75, 80, 85% of the athlete's pre-injury maximum velo is usually about a good time that it blends well into the slope. And the earlier you can get the athlete on the slope, working on the skill of working down the more time that they're going to have to work on their mechanics, get better sequencing, and overall just feel more comfortable as we try to ask them to progress further. We're not a fan of throw a 20 pitch bullpen at 50%, throw a 20 pitch bullpen at 75%, whatever it may be. We want to get the athlete on early. We want to continue to utilize our velocity progressions throughout this entire process. And realistically, after this point, over half of our throwing is taking place on the mound. And this also goes into another question that we need to answer, which is, when do we introduce off speeds and breaking ball pitches? Roughly at the same time. Now, we typically will allow the athlete to get comfortable with the fastball first in these positions, but over time, we can start to safely reintroduce off speeds and breaking balls at the same relative RPEs, same kind of velocity-based scales as the fastball. And we want to on-ramp these pitches early and give the athlete a large on-ramp time to get these pitches up to speed as well. We know from the literature that this is not going to place any significantly more torque on the elbow. And in fact, as you get into higher velocities, the fastball becomes the most stressful thing. So we can begin to reintroduce these pitches earlier, start to expose the forearm to the various positions that those dynamic stabilizers are going to have to operate within, and use a very similar mindset of progressing them slowly and specifically with a velocity-based progression to get it back up to speed. And as far as our mix of how much we're incorporating, we believe that it should roughly mirror what the athlete's utilization will be whenever they get back to in-game pitches.
I know there's one caveat to that, Matt. It's preliminary for us, but I know you've been involved in a study looking at supination bias type pitches. And I'm not sure if you want to just make a point about that.
Yeah, so I think Dylan brings up some great points on the early exposure to breaking balls, and how if you look at in the lab, mocap, whatnot, the lower velocity in which these breaking pitches are thrown imparts a lower level of force in the medial elbow. However, we've done a study, here, and a lot of this is helping Dylan, took kind of a spot analysis of a bunch of healthy throwers, and we tested their flexor pronator function in sort of the position of fastball release versus in a supinated position. And we did find that there were some differences based off of natural pitch bias. And so throwers who were self-described as natural pronators did demonstrate some decrease in flexor pronator function in a supinated position. And so that does, again, bring into an area where I think we need to be mindful on the reintroduction of breaking balls, because natural pronators may have decreased flexor pronator function in supinated positions. And we just got to be mindful of how their flexor is functioning, because we're imparting a different level of force on the medial level compared to a natural supinator. And so, again, this is all stuff that we're still learning and things that we're going to be adapting and changing over time. There's going to be stuff here that we're going to be wrong about and stuff that we're going to adjust. But this just shows the level of detail that we're seeking to figure out and to titrate.
Now, this kind of piggybacks onto the concept we were talking about with our suggested return to throw programs. Our goal through all of this is not to get someone just to the point that they can return to play, but we want them to be prepared to return to competition and hit the ground running as if they've not missed a beat. Part of that for us means we in the return to throw program need to be able to create the adaptations that Dr. Brolinson talks about and apply that stimulus. And to us, there's no better way to do that, to build capacity, still being respectful of the acute to chronic workload ceiling that we have to respect. But in our program, we have 17 days that we are having pitchers throw at max intensity before we get to the point that we're going to be ready to clear that person even to throw a single inning. And we think that better positions pitchers to come back and be fully comfortable, not just physiologically, but psychologically, to meet the demands required by competition. We probably should have said this earlier. I don't want anyone to think that everything that we're presenting here is purely academic in nature. We've used the better parts of all of these guidelines on over 300 plus athletes over the last year and a half, and have had great success in using these criteria and having people follow these programs. And as Matt says, it's something that we will continue to iterate on, but it's not as if we're just dreamed these up and then figured out we would just suggest others follow them without us having had lots of athletes go through them. Now, part of that dovetails into this concept of preparing someone to throw. And this is why, just if you prepare someone, even if you say you're going to prepare someone to throw a single inning, that doesn't mean they need to be able to make 20 or 30 max effort throws. If you just think through, for all of the baseball guys on this webinar, if you're going to prepare a pitcher to get ready to make a single 20 pitch outing, he's likely going to long toss. He's likely going to do some pull downs. Then he's going to throw a pin. Then he's got pre-game throwing. So before you know it, that guy needs to be able to make 75 to 85 pitches that are essentially max effort throws before he's fully prepared to go into a game and just throw 20 pitches. So for us, if you look at this in the way that we've built out our program, That means over the course of our return to throw program, still operating under a 1.3 acute to chronic workload, we've got a guy making over 600 zone 10 throws. We've seen other protocols that might have a guy make a total of 60 or 80 zone 10 throws over a period of 5 or 6 days, and all of a sudden declare that that guy's ready to return to competition. All that means to us is he's ready to return to play, but probably not going to be tremendously confident in his ability to do so. I mentioned this before. I'm not going to spend a whole lot of time going through this chart, but understand that because we have very specific criteria that we feel has to be met both systemically and specific to the forearm, we know that not everyone is going to meet that criteria. So we've created return to throw programs that are customized based on the actual performance and progression that our athletes are able to make in the forearm musculature that's most important to protect the UCL. And depending upon how players progress, that will determine how aggressive we can be on the return to throw program, and naturally then how long it will take them to get back to the point that they're going to be good to throw an inning, 2 innings, 3 innings, begin return to throw, any of those things. So rather than just having a single cookie cutter approach, we've at least started by bucketing people into at least 3 different buckets. And we think we will just become more customized in the process as we progress further. One of the hot topics along this whole concept of rehab is deload weeks. I know Dr. Brolinson, I put this slide in because I know you have some thoughts specifically about that. So I figured I'd turn this back to you.
Yeah, I think that just putting pre-programmed deload weeks in there just really physiologically doesn't make sense. We've talked about how muscle tendon units have to be stressed in order for healing to progress. So to just automatically throw in a deload week makes no sense to me. Now, if you've got somebody that's having arm soreness or some other difficulties, then a deload may make sense. But I think if you look at that chart that Daryl put up earlier, that one big dip was a deload week. And again, from my perspective, a deload week doesn't make any sense, because what we're trying to do is again, progress the healing process. And as I like to joke with my sports medicine fellows, healing is not a photosynthetic process. This stuff doesn't get better just with air, sunlight, and water, right? The tissue needs to be loaded and stressed in order for healing to progress. So that's why I just don't like the idea of a deload unless you're getting athletes getting into problems, having soreness, decreased velocities, things like that.
So Dylan, this is kind of, I think you can largely bring us home on this, and then Matt will close us out. But now we're back to kind of the same chart in terms of our criteria.
Yeah, and I mentioned it briefly earlier in the presentation, but we have our pre-return to throw criteria that we think sets the athlete up to be well supported throughout that process. But by the time we get to return to performance, there's largely not much that differs. We do want to see continued progression in our global strength metrics. We want the athlete to absolutely be as strong, if not stronger, than they were on a global scale. Our flex pro testing, we have kind of our specific targets there that we want to see athletes at compared to the targets that the Flex Pro team has developed. And then in terms of the shoulder, we just want to make sure that we've maintained or continued to progress upon what our minimum metrics were to even start the return to throw. And to play off of this a little bit and what Gunnar was previously talking about, a big signal for a deload week would be if we start to see any decline in these variables. So we believe that it's important that throughout this entire process, you're consistently monitoring and measuring many of these things. It doesn't have to be an obsessive degree, but if you can get consistent signal data from the athlete during this process, especially when you're making jumps in intensity, utilizing this data and monitoring that can also help prescribe your deload weeks.
So with that, I think we have one more. Matt, you want to summarize what we're trying to address here from a pure what we believe is best practice?
Yeah, so I think a lot of this comes down to what Gunnar mentioned earlier about the specific adaptations to the demands that we're asking on the medial elbow. And so, we're identifying the equation that you brought up earlier, Daryl, with regards to, we know the force that the elbow is going to have to withstand. We know what some of the static stabilizers are. We don't know how to affect the underlying ligament per se yet, but we know that the overlying flexure is something that's trainable. It's something that's attackable, right? And so let's identify some of these needs, identify the flexor pronator needs, identify some of the other fundamental things that Dylan highlighted with regards to strength metrics and what we expect of the athlete before they get out and ready to throw. And so let's meet these thresholds as we're returning them to throw, as returning them to a higher level and hopefully to performance. And I think utilizing velocity-based progressions and workload monitoring with or without the use of a wearable as well, it's the key to progressively loading the tissue, because the tissue is going to respond to load. All right, we want to minimize these acute spikes, and we want to be aware of how the athlete's feeling, how they're adapting, intervene when needed, and then understand how those deloads affect them, right? So the deload affects that acute to chronic workload ratio, and so we may have to make further adaptations down the line as we ramp them back up. And so the goal is, to build that underlying volume that these athletes can then perform upon. And so I think that's the kind of the key fundamentals of the guidelines.
And with that, guys, we're done. We certainly thank you for your time. We're just shy of an hour. There may be a time for a quick question or two, but again, as I said, if you have questions, put them in the chat. We'll leave the channel open for a bit and happy to stay on if a few of you want to stay on. But other than that, if questions appear in the chat, we will go through it. We will answer all of them, and we will send out a document. We will also send out the full narrative guidelines and the attachments, and encourage you to read through those at your leisure. They'll provide all the supporting information to everything that we've discussed, and contact information for any and all of us, so that feel free to reach out to us. In the end, as most people say, it takes a village. We started this process, but we don't feel like we're working in isolation. We would love to continue to engage with all of you to ultimately do what all of us want to do, which is to figure out how to first keep guys healthy, but for guys who get injured, to figure out how to improve the rehab process so that we can dramatically improve upon that number to date, which again is somewhere in the neighborhood of half to greater, or really not making it back to prior levels of performance in a way that we would want them to be able to do so. I'm going to pull off the share screen. Matt, Dylan, Gunnar, do you guys have any closing thoughts before we might pull up a question or two if people want to stay on?
In closing, I think the whole pursuit here is just to try and facilitate the process of constantly analyzing what we're doing, why we're doing it, and how we can do it better. And again, I think this is very much a living document. This is going to change. There's going to be stuff that we got wrong. There's going to be stuff that we got right. And I think it's just the mindset of taking the next step, knowing that the rehab process after UCL injury and UCL surgery has been sort of ripe for improvement, just because historically we just haven't done as good of a job as I think we've hoped, and that's the goal here. That's the goal here, is to use some of the tools that we have and be thoughtful about progression, and loading and adaptations are what we're seeking.
The other thing I'd add to that is my hope is that as we accumulate additional data, and like Matt says, some of this we're going to get right, some we're going to get wrong, but I'd like to really think about this from a prevention perspective. I always say my goal is to try to keep you from going to see the surgeon. So I think that we've got some ideas here in terms of utilization of the device to help prevent injury. So I think that for me is kind of the holy grail with this ultimately.
Yep, and my final piece would be I think that we've continued to build on all of the work that has existed prior, and I think that's really the focus, is that we're just trying to make the next step. We know that it has been around for many years, and it's kind of been the status quo. We think it's time. We think we have enough experience, and we have enough kind of anecdote to say that we can do things better. And here's our suggestions on how we start to move that needle forward.
So with that, we are actually right at an hour. We always promise to keep these to an hour. We've not had any time, obviously, to handle questions. We will handle every question that appears in the chat. So get those. I don't want to speak for Dylan, Matt, and Dr. Brolinson, but I'm certainly happy to stay on to address some questions if you guys wish to stay on. So why don't we try to do that? And if you need to drop, by all means drop, and then we'll address as we go. Dr. Fury, Brolinson, do you guys have a few more minutes, or do you guys have clinic, or what's your schedule?
I've got a few more, and then I'll peel off the clinic just shortly.
All right, let me see then, Dr. Fury, if there's one specific to you. I think there was one I saw about, I'm just not.
I think we can touch on the supination pronation bias.
That's what I was going to ask.
Which came, I think.
So I'm sorry, Matt, let's ask the question. So the question was, can you elaborate on supination bias caveat? Is this for those who are self-described pronators or supinators? as a PT professional and an athlete without a reliable pitching coach, how do we determine this?
Yeah, I think a lot of, not everybody falls into these discrete buckets, but a lot of throwers have a predisposition with regards to some throwers have a natural cut, and that ends up being what we consider a supination bias, while other throwers are a little more comfortable generating some arm side movement, and that's where the pronation bias comes in. And a lot of this is subjective, which then manifests into objectivity because they tend to have a predisposition to favor these arm side run or favor either cutters, sweepers, sliders, or whatnot. But the point is, we did this study looking at how forearm position affected certain elements of the flexure, and we found that when you asked players how they describe themselves, hey, are you a pronator, are you a supinator, there became a little bit of a division, and people that were naturally more comfortable with a pronation bias, so with arm side run, when you put them in supinated positions, they had some drop offs in their overall flexure strength. And so I think this just indicates that certain throwers are more comfortable doing certain things. Now, are they more comfortable that way because their flexure works better in that position? It's, chicken to the egg. I think you can get into that argument, but I think the point is to treat every thrower differently, right? And understand that we can measure some of these things and we can prescribe them differently based off of their underlying biases, their underlying, phenotypes and differences, and try to, again, smooth out some of these big spikes. Because if somebody's got a little bit decreased forearm flexure function in a supinated position, if they're a natural pronator, then we just have to think about what that volume means of the off-speed pitches that we're introducing, right? A little bit differently than the contrary for a supinator. And so it maybe introduces more questions and answers, but I think it just shows that every thrower is different, and we're trying to find ways to adapt it to the individual.
Bill, there was a specific question about use of BFR, and maybe can you expand a little bit upon your use of BFR and where you find it useful and how you go about doing that?
Yeah, and there's a little bit of controversy to some degree around when we can start using BFR. Some people like to use it early while swelling may be still present, and some people anecdotally kind of note that they find it maybe helps clear swelling. Regardless of when you use it, typically once you have full range of motion is when I will start using BFR, even if there's maybe a little bit of puffiness still visible. But it's just my way to get more out of the early stages of reloading. When you're in that 5 to 8 week period, you're not utilizing very heavy loads whatsoever. And you're really just working into re-exposure for the tissue. You're not stimulating it enough to actually stimulate any kind of hypertrophy or other adaptation. So BFR is a nice way to kind of enhance that, because we do know that we can take those light loads and get a metabolic effect to potentially stimulate some hypertrophy or other things. So it's just one of the tools that I like to incorporate really early on whenever I'm reintroducing these loads to start to get this metabolic effect and potentially some hypertrophy during a period of a little bit of atrophy that they may have developed before and in the early stages of surgery.
Dylan, I think we kind of addressed this, but it was related to a slide. There was a question about thoughts on introducing different pitches during catch play at submax effort to regain some comfort with throwing them with grips and the like.
Yeah, and we mentioned it specifically in the context of like doing it on the mound. But there's absolutely room for you to start introducing the changeup, the breaking ball, whatever, all your various grips in very light catch play. We kind of mentioned that we recommend a usage rate that's similar to their arsenal, and that can apply to their lower intensity throwing days as well. It doesn't always have to be done at the max intensity. There's value in building confidence with higher frequency of lower relative stimuli compared to what they're currently at. So yeah, you can definitely incorporate them early, often, and get more touches on it before you start asking them to really make significant progressions as well.
There's a question that I'll start with, and then obviously anyone else feel free to chime in on. But one of the questions was, do we have any other data besides our own subjective survey data to validate thoughts on how many number of throws equal a single throw? And the short answer is no, we don't have it, because we've looked. There is no objective research. The IMU, or the throw valuation data, if you will, that much of the industry is operated on is based on the IMU data that first came out of Modus, now Pulse. And their valuation method is actually based on a NASA bone density study. And that's it. there's no question that those who are skilled in using that device can do a wonderful job getting the data off of it and then making changes to bucket how many throws you're going to let someone make in a zone 3, a zone 4, a zone 5. But if you ask a pitcher whether or not, quote, a zone 5 throw and the number of throws that they are assigned to make that are supposed to equal a single max effort throw, if that actually represents their reality, they will tell you not even close. So what we've tried to do is build a model that we thought was more representative to match what a large population of pitchers told us to be the case. And as I said, that's something that I think is a wonderful topic for further research, because the harsh reality is we really don't know how the relationship of sub-max throws works to build capacity to throw at high intent. One of our contributors, Casey Mulholland, talks about the concept always of looking at marathon running when he's explaining the concept of acute to chronic workload ratios. And we would use the analogy and say, if Usain Bolt was training to win an Olympic medal, there's no amount of mile runs or jogging, I don't care how long he jogs, that's going to prepare him for a max effort sprint. So again, that's that said principle. And what we really know is we need to be able, if we want guys to be prepared to throw at max intensity and build up the tissue capacity to handle it, we need to prepare them to throw at max intensity. And we frame that when you look at, if you look at our guidelines, when we start bracketing how we assign volume across different zones, we're very, very specific about the amount of throws we think need to be made to make sure that we create a nice progressive accumulation to get guys where we really want them to be, which is handle max effort throwing. Gunnar, Dylan, Matt, if you think I missed anything on that, by all means, chime in.
I think you're good. There's a question in here as well from thoughts on utilization of a throwing sock prior to first throws and during deload periods. And I want to kind of expand on that question a little bit as well. So throwing sock is just like it's like a mitt that you put on and the ball just like releases and goes into a sock essentially. So you kind of fake throw it, if you will. You don't see it go anywhere. Yeah, it could be a tool. It could definitely be utilized as a way to reintroduce throwing in a very low threat environment. When you're working, especially if you have the opportunity to work one-on-one with an athlete, those first couple of days or weeks of the return to throw can sometimes be anxiety ridden, and they get really concerned about their mechanics and all of these other things. So yeah, especially in the late stages of rehab or right before you start throwing, doing things that maybe reduce the pressure on the athlete is good. And then utilizing deload periods, yeah, it could definitely be a tool there. Deload periods in general, the way that I think about it is I just want to remove like my top 20% of peak stresses that they're experiencing, wherever that may be in the progression, and I want to reduce it down and then rebuild that back up. And then to expand on that question a little bit, to some degree, it's speaking to the utilization of various constraints in a return to throw. Not every throw needs to be made with a baseball. Every throw, you can utilize overload balls, underload balls, footballs, other things. And the more experience that somebody gets with return to throw, especially if they do this a lot, the more comfortable they'll be breaking away from these guidelines a little bit over time and modifying them to what they like to do and what fits. Yeah, I think there's room for this. Just in the guidelines that we're providing, it's just kind of assuming we're going to utilize a consistent standard baseball and velocity progression, and then more skilled practitioners can start to deviate as they see fit.
Dylan, I think you brought something up earlier in the presentation about the reintroduction of valgus loading the medial elbow and sort of the various phases. The whole goal of demonstrating that the elbow is, to impose these stresses that we know it's going to have to withstand, but at the same time, psychologically, you're also taking the athlete on a journey too as well. Right? Yeah. With regards to experiencing stress over the medial elbow, with regards to rebuilding the strength to where we get to the point where we use other implements, plyos, other things to demonstrate like, hey, we're ready. And I can tell you that, as from the surgical side, but also as a patient, I had UCL surgery when I was in college. And I can distinctly remember the time standing on the field, staring at a baseball in my hand on day one and being like, all right, I wonder how this is going to go. in my head, right? There's a psychological aspect of return. There's a psychological aspect of recovery. And you really shouldn't feel that. You shouldn't feel like, oh, I wonder how this is going to happen. You should have proven to yourself all along the way that I am ready to withstand this. I have built this capacity. I've built this resilience, and now I'm ready for this moment, right? And I think that's part of what you delineated very clearly earlier. The whole idea is just showing the elbow that it can withstand the things that's going to be expected to do.
Yeah, and I always harken back to our friends in the ACL field because there's so much more, it's much broader, much more deeply researched, and you'll never see a soccer player going back to the field at a high level when they haven't done a ton of high velocity, change of direction work, exposure, chaotic environment stuff, because the entire purpose is to re-expose the stress and improve the psychological aspect and make them feel confident. And we don't really do that in baseball. We just kind of, like you said, hand them the ball and say, good luck.
There's one question, and maybe unless there's one that you guys feel like we should address in addition, maybe we can take this one and stop and then just address the rest offline. But the question had to do with someone who said that they don't have access to an IMU. So what's the best way to go about progressing guys through rehab if they don't have access to an IMU? Should they use RPE there? How should they use it? And I think our response to that, I think Dylan addressed that in the presentation, was that absent an IMU, we feel like velocity by far is the single best modality to use to progress someone because it has the highest and strongest correlation to elbow valgus torque throughout the throw. So it's hard for us to think that someone who's going through rehab from any sort of UCL or flexor injury would not at least have access to buying a pocket radar. And what we would suggest, and that's completely delineated in our return to throw protocols, is zone progressions, which for us would be velocity ranges that we think someone should throw at. And our suggestion to anyone managing someone's return to throw is at a minimum, if you do not have an IMU, just get a pocket radar and make sure that you define the throwing ranges that you would expect someone to throw at. And that will give both you and the athlete a very, very good indication as to whether or not the athlete is progressing according to schedule. And with that, then you can start to prepare, you can again to compare how the athlete's progressing on what matters to him most with throwing to the objective data that we would expect the athlete to be hitting to see whether or not plateaus are occurring either in his strength, his rate of force development, power, endurance, any of the metrics that we now have the ability with FlexPro Grips technology to objectively measure. Dylan, anything to add to that? If not, then let's just wrap it up.
No, the only thing I would add is I don't want to also overemphasize the zones and things like that. Like, we do believe that the vast majority of the throws that you make should fall within the zones. But if you break that on one or two throws, it's not the end of the world. The model isn't destroyed. You don't have to scold the athlete. The athlete doesn't have to feel ashamed or whatever. The goal is to provide a progressive but relatively consistent range for the athlete to operate within during whatever throwing session that they may be working through, and just to minimize the likelihood that they're going to begin to exceed the desired intensity progression that we want them to. So it's not the end all be all, but it is our just most consistent and reliable tool.
So what I'm going to do, and Dylan, I'll ask you to do the same. Obviously, we'll address everyone's questions, as I said, online. But if you, Dylan, maybe can just put your email in the chat so that everyone has that directly. So if anyone wants to reach out to you directly, they have a way to access you. They'll see it in the guidelines, but I wanted to just put that in and make that available now. I can type yours in, Dylan, if you don't have access.
Okay. And then somebody asked if they have to buy anything right now. No, I believe everything we're sending out is
everything
to
is
everybody.
Yeah.
Free. Everything is going to your email. And then feel free to please ask a lot of questions based off of those emails that you get with after you've had time to sift through them. Feel free to offer your critique as well. We are open to the feedback or challenges to what we have presented.
Wonderful. To everyone, thanks so much for your time and for joining us. And we look forward to further dialogue. Great seeing you. Thanks as well.
Thank you.